Welcome to Roadmap to Residency. Hello, everyone. I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We are currently in our hematology sessions. We will be running through a question with you guys to help you on your journey to a 250. So, what type of stem cell transplantation is being described in this case? A 40-year-old patient with relapsed lymphoma is being considered for a treatment approach that involves harvesting the patient's own hematopoietic stem cells for subsequent transplantation. The goal is to provide high-dose chemotherapy and then reinfuse the patient's own stem cells to restore the bone marrow function. What type of stem cell transplantation is being described in this case? Allogenic, xenogenic, autologous, synogenic, and haploidentical stem cell transplantation. So the type of stem cell transplantation being described in this case is autologous stem cell transplantation. So the definition of autologous stem cell transplantation is the autologous stem cell transplantation involves harvesting a patient's own hematopoietic stem cells before undergoing high-dose chemotherapy or radiation therapy. Now, after the intensive treatment, the harvested stem cells are reinfused into the patient to restore the bone marrow function. The indications of autologous transplantation. The autologous stem cell transplantation is often considered in cases of relapsed lymphomas or other malignancies. The procedure allows for the administration of higher doses of chemotherapy than would otherwise be tolerated, with subsequent reinfusion of the patient's own stem cells to minimize the duration of bone marrow suppression. Now let's talk about the stem cell transplantation. So hematopoietic stem cells have the ability to divide and multiply, that is self-renew, and to develop, differentiate into different types of mature blood cell. And these are used to treat the patients with disorders of the blood, including some cancers. Okay, so hematopoietic stem cells undergo self-renewal and differentiation. So how we do the autologous stem cell transplantation? So first we do is stem cell mobilization, where the patient gets treated with certain drugs that will cause the body to produce more stem cells and cause the movement of the stem cells from the bone marrow into the bloodstream. After that, we collect those stem cells. The patient's stem cells are collected from either their blood or bone marrow, and blood is taken from a vein in the patient's arm. And then we do processing of these stem cells. The blood is processed through a machine that removes the stem cells, and the stem cells are frozen, and the rest of the blood is the return to the patient. And after that, we do conditioning and treatment. The patient receives high dose chemotherapy with or without radiation therapy to kill the remaining cancer cells, and also gets rid of the blood producing cells that are left in the bone marrow. So now everything is gone in this patient. Now what we do is that we infuse the same stem cells that we took out from this patient. So we reinfuse into the patient the frozen stem cells, which are thawed and infused back into the patient. And the stem cells travel to the bone marrow and begin producing new blood cells. So whenever patient have any blood-borne cancers, then we just take out the stem cells that are able to produce blood, and then we just destroy everything in the patient, and then we again transplant the stem cells. So pretty much fantasizing technology out there. So there is something also called as analogous transplantation, where the blood is collected from the donor cells, and the blood is collected from the donor's blood or bone marrow or from an umbilical cord, and the blood is taken from a vein in the patient's arm, and we do the processing of that blood, and we again do the conditioning and treatment, and again after that we infuse the blood to the patient. So now let's talk about some other topic. So what is the most likely diagnosis for this post-transplant complication? So a 55-year-old man with acute myeloid leukemia undergoes allogenic hematopoietic stem cell transplantation from his human leukocyte antigen-matched sibling. Several weeks after the transplantation, the patient develops diarrhea, skin rash, and hematomegaly. Lab tests reveal elevated liver enzymes, and skin biopsy shows epidermal apoptosis and lymphocytic infiltration. What is the most likely diagnosis for this patient post-transplant complication? Now, graft rejection, neutropenic fever, engraftment syndrome, graft versus host disease, or post-transplant lymphoproliferative disorder. The patient most likely diagnosis is the post-transplant complication, graft versus host disease. The GVSD is a common complication of allogenic hematopoietic stem cell transplantation, particularly when the donor is HLA mismatched. The classic presentation includes diarrhea, skin rash, and hepatomegaly. The timing of graft versus host disease typically occurs several weeks to months after allogenic transplantation. Acute GVSD can present in early post-transplant period and affects the skin, GIT, and liver. The skin biopsy showing epidermal apoptosis and lymphocytic infiltration is consistent with cutaneous manifestations of graft versus host disease. So the type of transplant rejection, which is caused by the immunocompetent donor T cells reacting against the recipient MHC1, that is the foreign antigens. They can be variable time course of symptoms. The common targets are the skin, liver, intestine, epithelial tissue. The donor CD4 plus T cells recognize the recipient MHC as a foreign antigen, and it activates the activated donor CD4 plus T cells. Then the cytokine gets released, and the recipient macrophage CD4 plus recruitment happens, which exacerbates the cytokine response. The tumor necrosis factor alpha is the possible cause of muscle wasting in this patient. The donor CD8 T cells recognize the recipient MHC1 as a foreign, and activated CD plus T cells and porphyrin-mediated cytotoxicity occurs, and the majority of tissue destruction occurs via the CD8 plus T cells. So both sides are playing, the donor and also the recipient sides are playing here. And there is similar graft versus leukemia reaction beneficial in individuals with leukemia due to ability to help eliminate the recipient's hematopoietic cancer cell line. The risk factors maybe liver, bone marrow transplants rich in lymphocytes, and T cell immunodeficient individuals, or newborn patient. The signs and symptoms include metabolic wasting, failure to thrive, maculopapular rash, jaundice, bloody diarrhea, and hepatosplenomegaly. Diagnosis, lab results. Histological analysis of easily biopsied tissue in individual with history of transplantation. Liver, skin, GI tract are the most helpful in chronic indolent disease. Other diagnostic may include a clear clinical presentation where we can have a constellation of symptoms. The treatment is generally prophylactic cyclosporin and some site-directed corticosteroids. Other interventions may include proper donor, a recipient human leukocyte antigen, and a minor histocompatibility matching. So here we can see a CT scan in the coronal plane of the abdomen of an individual with graft versus host disease. The GI tract, including the stomach and the small bowel, is grossly edematous, guys. So you can see the colonic biopsy taken from an individual with graft versus host disease, where there is a fibroid cryptitis and apoptotic debris at the crypt abscesses. Thank you for watching. Keep studying hard.